So welcome to the first webinar on behalf of East Cheshire NHS Trust and Manchester Medical Academy. My name is Manaiz. I'm the consultant in emergency medicine working in District General Hospital, as well as the director of Manchester Medical Academy. And here I'm joined by my esteemed colleague.
My name is Michael Crook. I'm a clinical vascular scientist working at East Cheshire NHS Trust.
And today we will be talking about the topic, which is when it's not a DVT. So the reason being it's quite close to my heart is over the last few years, we came across cases. I and Michael always discuss cases because we present them at different levels, either whether it's in the grand round or in our academic courses or in the trust. So there were a few cases which we came across and they were quite critical. When I say critical, time critical. And the diagnosis was a big dilemma because the presentation was much like a DVT and they turned out to be not a DVT. And then a few cases were DVT, but then the usual treatment protocol, which is for the DVT, wasn't useful in those cases. If we followed the usual pattern, unfortunately, it would have been catastrophic for the patient. So I and Michael met up and we decided that it would be good to share these clinical cases with the globe. And hence why we decided to do the topic when to DVT. So what we're going to be doing is we're going to be starting with, so we're going to present 4 cases, two by myself and 2 by my colleague Michael. Each case will be started with the case history, and then we'll ask for you guys interaction. So you could put anything in the chat when we ask you to give your suggestions or differentials or anything like that. Each of the cases will be followed by images, and we will go through the images together. And then we will come to the final conclusion, what the outcome of that patient was and how the point of care ultrasound helped us to diagnose that area. The main emphasis which we'll be putting on in this presentation is the role of the point of care ultrasound and how it could be used as an adjunct to your clinical history, examination, as well as with the rest of your investigation and how it could change the patient trajectory and where they're going to go. So without further ado, let's start our first case. I'm going to start sharing my presentation, and if you could kindly thumbs up if you could see my presentation. Thank you. Thank you, guys. Yeah, really appreciate it. So the first topic, first case which we're going to be going through is this one. So this was Saturday morning. A 59-year-old male woke up that morning. He was unable to move his left arm. He was complaining of pain in his left arm. His background history was type 2 diabetes. He was unable to move his left arm completely. So he called the ambulance. When the NOS trains for Northwest Ambulance Service, they went to see him and they found him that his blood pressure was high, 175 over 110. He was tachycardic with his heart rate of 115. His saturation was normal. His GCS was 15. And there was no focal neurology other than the left arm that he could not move. And his temperature was 36.7. So they thought that keeping with the fact that he's not able to move his whole left arm, also it was swollen as well. So they thought it might be a stroke, it might be a big DVT. So they asked the cell center and they said, keeping with the fact that it's just the focal limb neurology, it can't be a stroke, so it should be taken to the local hospital, hence why the patient landed in our department. So I would like you guys, this is your patient, and what would you do? If you could kindly use the chat box and we'll give it a minute. There is no wrong or right answer, and there would be no blame or shame game. So you're more than welcome to write what would you do. Okay. Excellent. Yeah. Yeah. Okay. Okay. So absolutely, we'll do the examination as we always do. So on examination, we see that the left arm is swollen and tender, and there is no pulse. So the registrar who saw the patient, and keeping with the fact that the patient had no pulse, his left arm was swollen, it was tender, and it was paralyzed as well because he wasn't able to move his left arm. So he thought that it might be a massive DVT or a compartment syndrome, or the fact that the patient is not having the pulse, to that it might be arterial ischemia. So what do you do next? I'll hold on for a minute, and I would like you guys' answers. If you could put it in the chat, that would be really useful. Anything is?
I think we've disabled it. Yeah, it says the host has disabled the complete chat.
No. Yeah, ECG, loads, D-dimer drop, left abdomen X-ray.
Okay. Anything else? Okay. So ECG was excellent. It's a good call. ECG showed sinus tachycardia, so it wasn't atrial fibrillation. So a good thought if some of you guys were thinking of the emboli. So yes, it wasn't atrial fibrillation, it was sinus tachycardia. The second thing which you said about the blood, so obviously the bloods were taken, the venous gas was done, and his lactate was 2.2. Other than that, nothing else was abnormal on the blood gas. X-ray wasn't performed, and keeping with the fact that the patient did not have the pulse palpable. So the registrar thought that it might be acute arterial ischemia. So they called the vascular team, and they agreed that if the distal pulses are not palpable, the patient would have the pain. So he had all the classic triads which you would get, all the 6 symptoms which you would get, like the pain, paralysis, peristyle, coldness, of the signs of the arterial ischemia. So they said, load the patient with heparin and transfer. Would you guys agree? I'm really sorry. I would have to keep you involved because I can't see you guys. So usually when we do these talks, it's really interactive. But that's why I thought a bit of it would be useful if you guys could chat in the chat box, and then we could go further. So like you said, examination, ECG was done, examination findings, there was no pulse palpable, the hand was cold and it was swollen, and the patient was complaining of severe pain. So the registrar decided that it's an acute arterial ischemia, so he called the vascular team, and we did not wait for the blood test because when it's a time-critical diagnosis, we do. And the vascular team said, load the patient with heparin and transfer him over on heparin infusion. Would you guys agree with it? Anything?
Just trying to enable the chat. Ultrasound, not done.
Well done, yeah. Hence, it's a POCUS talk, so of course we should do the ultrasound. So that's what we did for the patient. And this is the ultrasound I'm going to show. I'm not going to bore you guys with the images of the arm because there was no arterial pulsations, but there was all the veins were compressible. So we came up to the axillary vein, and we were quite happy that all the veins were compressible, but there was no arterial flow on the Doppler as well as on the normal B scan. So I'm just going to show you the heart. That's where we went to the heart. And I'm going to play it a few times. And then I'll show you guys the zoom view as well. And I believe you all could see this. So this is the descending aorta. And you could see that there is a dissection plaque in it. So a big dissection plaque going through and through the vessel, which is what prompted me that it's not the case of the arterial ischemia secondary to the emboli or anything. It's basically the dissection, which is the cause of the patient's symptoms, and hence why we had no distal flow. This is what we do whenever we do the aortic root measurement. So this is at the synovial junction, which you could see in here. Sorry. So it's 2.9 centimeter, and at the aortic junction, it's 3 centimeter in here. And then I would show you the aortic root in here, which is 5.2 centimeter, which is anything which is more than 4 centimeter, I really get worried about them. And I could show you the flap as well, if you guys could appreciate it. So that's the dissection flap in here. Let me show you it from more zoom view. If you could see in here, that's the dissection flap in here. So that was a case of type A dissection, Stanford A dissection. This is the color flow, which you could see quite clearly. So from this case, just imagine this patient who came in with the classic symptoms of DVT, which we could see pain, swelling, as well as warmness to touch. And sometimes when it's severe, you could lose the pulses as well. The same symptoms are there in the compartment syndrome as well. And unfortunately, the same symptoms are there in the aortic dissection as well. So just because we did the point of care ultrasound, it changed the patient trajectory, because if it was a compartment syndrome, they would have been under the orthopedic surgeon. If it was the only the upper limb DVT, it would have been the patient would have been under the medicine. But if it would have been just the arterial ischemia, the patient would have gone to the vascular team for the intervention. But the fact that it was dissection and it was at the aortic root level, it needed completely different specialty, which was the cardiothoracic. And that's where we transferred the patient without doing any further investigations in our department. We transferred the patient, and the patient had the aortic root repair, and the patient had successful outcome. So this was my first case. I want you to keep in mind, whenever you come across a patient who have these typical symptoms, which looks like a DVT, which looks like a compartment syndrome, it's always my favorite go-to to make sure that it's not arterial dissection. The other case I came across was compartment